Hi, everybody. This is your review for assessing children, infancy through adolescence. Some areas that you, of course, will be assessing through each visit: your physical development, and this should be assessed in depth during each visit. And then any cognitive development, not any, but you would look for a cognitive development and social and emotional development. Now, with any of these, if there seems to be some sort of impairment, then you would want to assess a little bit deeper. So it's the same concept when you're doing a focused exam versus comprehensive. You're going to focus in on the areas that might be showing potential impairment. You want to make sure you're familiar with all the stages of development from newborn to infancy, which is 0 to 12, early childhood 1 to 4 years, middle childhood 5 to 10 years old, and then adolescence from 11 to 20, and that's broken up in the different categories of early adolescence, middle adolescence, and then late adolescence. With our kids, you want to be measuring height and weight during every visit. That's going to help calculate your body mass index. When you have a newborn up to 36 months, you want to make sure that you're assessing the head circumference due to the increasing in growth and the rapid nature of the growth. You're going to start measuring blood pressure around age 2. And then, as we all know, in infants, the heart rate will be higher, and then it will slow down as they get older. Same goes for respiratory rate. And then to check temperature, if they are younger than 2 months old, you want to be still using the rectal thermometer. And then anything greater than or equal to that 2 months, you can then go to the tympanic temperature. Of course, depending on where you're working and how they're presenting might depend on how you'll take their temperature. But we all know that the rectal temperature is the most accurate. Here's an example of a sequence of an exam. Of course, careful observation of their activity. Then looking at their head, neck, heart and lungs, abdomen, GI system, then moving down to the lower extremities, their back. Doing the ears and the mouth and eyes whenever they happen to be spontaneously open. Doing a thorough skin exam. You want to assess for the vernix caseosa, which of course will be present at birth, and then lanugo, that will shed within the first week or so of life. Then doing a nervous system assessment and then checking at their hips, making sure that they're in correct alignment, not displaced. And then this chart, the APGAR scoring system, this is done at 1 minute after birth, followed by 5 minutes after birth. And what you're doing is you're hoping that those numbers will increase. So you're looking at heart rate, their respiratory effort, the muscle tone, their reflex ability, and then the little newborn's color, skin color. Obviously, what we are hoping for by the 5-minute mark is that their heart rate is over 100, that their respiratory effort is nice and strong. You hope you're getting a nice, real good cry. That they have active movement for muscle tone. Their reflex irritability, again, being able to cry very vigorously. The thing about those that work with kids, and specifically infants, newborns, is that if they're crying, that's a good sign in terms of things are doing well. Especially if you're doing an exam that would cause distress to a normal infant, and if they're not crying, that's usually not a good sign. And then their skin color, we want them to be nice and pink all over. But you want to be familiar with the APGAR scoring system because you will see this on an exam coming up here during this course. And of course, depending on what area, what specialty that you'll be working in, you might see this on a board exam as well. But it's important that you are familiar with the APGAR scoring system. When you're assessing an infant, so that's 0 to 12 months, this is where they're going to have their most rapid rate of growth, as their birth weight will triple and their height will increase by about 50% by the end of the first year. In terms of the sequence of exam, you always want to do things that are non-distressing to the patient, then followed by anything that would be a little distressing, so checking the ears or the mouth, or the abdomen, for example. So what's the rationale behind that? Well, if you want to be able to listen to heart and lungs, it's easier to listen if the baby's not crying. So when you're assessing the head, of course, you're looking for symmetry with light palpation. We know that the anterior fontanelle will close between 4 and 26 months of age, and then the posterior fontanelle will close by 2 months. So we know that the posterior fontanelle closes first, and then the anterior fontanelle closes last. You want to inspect the sclera, look at the pupils and irises, checking for the extraocular movements and any presence of a red reflex. In the ears, looking for the positioning of the ears, looking for shape and symmetry, and the patency of the ear canals. And you can here assess the acoustic blink reflex. Looking at the nose and paranasal sinuses. So infants are nasal breathers for the first 2 months of life. And then only the ethmoid sinuses here are present at birth, and then you want to inspect the position of the nasal septum. Then when you're looking at the mouth and the pharynx, of course, just as you would any other patient, checking and inspecting for the mucosa, looking at the tongue and gums, hopefully not two tongues, but the gums and the tongue. Looking at the palate and what their tonsils look like, and then what the posterior pharynx is looking like. You want to make sure that everything is patent, open, and clear. You know, same thing, you're looking for any abnormalities. You can start to palpate the gums and teeth. So teeth around 6 to 26 months, and that usually they'll be getting one tooth approximately per month. And that we also know that the central and lateral incisors will erupt first, and then the patients will get the molars last. We know that most infants, they have necks, of course, but in body proportion, it looks like they don't have much of a neck. So it's of course important to be very careful in this area, but also to assess thoroughly. So you're inspecting for any masses, and you want to palpate for any adenopathy, and this would be unusual in infancy. And of course, assessing for mobility of the neck. So remember, though, that we always have to support the head and neck of these infants. So here's a question. If a mother presents to the pediatrician that's concerned that her 8-month-old child is not developing appropriately, she bases this concern on the fact that the posterior fontanelle closed 6 months ago, but the anterior fontanelle is still open and soft. So your response to this concern is based on which fact? That the anterior fontanelle closes between 4 to 26 months of age, that both fontanelles should close within 2 to 4 months of age, or 2 months of each other, that the posterior fontanelle has closed early, or none of the above is true. And we know that the anterior fontanelle closes between 4 to 26 months of age, because the posterior fontanelle closes by 2 months. So remember, posterior first, followed by anterior. When you're examining the thorax, we're inspecting for the respiratory rate, the effort, the color and nasal component of the breathing. You want to listen for any audible breath sounds. Here you can palpate for tactile fremitus if the infant is crying or just making noise in general. Percussion is not helpful in infants, as we know that the thorax is more of a round shape in infants than in older children or adults. You want to auscultate the lungs. Usually the sounds are going to be a lot louder and harsher in our infants, but you do want to be able to distinguish between the upper and lower airway sounds. Usually with the upper airway, you're going to have more of that loud, symmetric sounds, and these sounds are usually more coarse during the inspiratory phase. So then if they're coarse in the inspiratory phase, then you would think that during the lower when you're assessing the lower airway, that the sounds are going to be louder over the site of any pathology that might be there. Um, Looking at symmetry, and then often has that in the expiratory phase. So you want to make sure that you know the difference between the upper and lower airways of our infants. And if you think in terms of anatomy, think about your basic BLS and um, how that all works. So if you're strong in your BLS, then you should know pretty well with your anatomy physiology. When you're assessing the cardiovascular system for our infants, of course, you want to assess for any cyanosis. You can palpate the peripheral pulses, especially the brachial. So going back to your basic BLS, where do we assess? Where do we assess a pulse in our infants? We know the brachial pulse. Whereas in our adults, we check for the carotid pulse, but we know that in our infants, we're checking for the brachial pulse. The PMI is not always palpable, but it will be usually one interspace higher than in adults. You want to palpate for any thrills as well. Now, when you're auscultating the heart, the S1 and S2, just like any other patient, but the split is normal, but will eventually fuse together as a single sound during deep expiration. S3 is frequently heard and is normal for our infants. And then if you assess or auscultate any type of murmur, you want to assess whether it's a functional murmur versus anything that might be pathological. Inspecting the breast area for infants and enlarged in newborns, which would be secondary to any maternal estrogen. That will eventually go away, so then you want to also palpate for any masses. Male genitalia, of course, just inspecting, looking for any issues there. And then you can palpate for this descent of the testes into the scrotal sac. Whereas female genitalia, it's important just to inspect, looking for any abnormalities there. In the abdomen, the umbilical cord, that remnant there is usually gone by the first 2 weeks. You always want to auscultate for bowel sounds. Now, in palpation, the liver edge is about 1 to 2 centimeters below the costal margin, and that's considered normal. And then if you can palpate the spleen tip, that might also be normal in our infants, whereas usually if you won't be able to palpate that in our adults. Or if you do, then there's a issue with splenomegaly potentially. And then usually a rectal exam is not generally done. In the musculoskeletal, you're inspecting the spine, palpating the clavicle, the hips and legs and feet. Here you're checking for symmetry and any obvious deformity, because we know that bow-legged growth to about 18 months of age is considered normal. So if you know what's normal, it'd be easy to find out what's abnormal. In the nervous system, you're going to be inspecting motor tone, and by palpating the motor tone through passive range of motion of all the major joints. And consider normal reflexes for newborn. They'll have the palmar grasp, plantar grasp, a moral reflex, asymptotic neck reflex, and positive support reflex, anal reflex, and positive Babinski. In infancy, triceps, the brachioradialis, and abdominal reflexes start to be presented during once they become around 6 months old. So you want to use that therapeutic communication with your young children as well, still making sure that you give them that reassuring voice throughout the exam. Sometimes it would be appropriate to allow the child to kind of see and touch the things that you'll be assessing them with. The reflex hammer, showing that it shouldn't hurt, and a pulse oximeter if you're assessing, with having them look at the light. Now, at the same time, sometimes what I'll do is I'll do the assessment on the mom or the parent or whoever the child's with at the time, to show that they don't have that it doesn't hurt or it's not too scary. And of course, depending on how old the child is, sometimes I'll even have them assess mom or dad or the guardian that's in the room with them. You want to avoid asking for permission to examine because more times than not they're going to tell you no, and then if they tell you no and you do it anyway, then you're not really building that rapport there anymore. However, you can always, depending on their age and their development, you can give them options of which area they want to have examined first. With our children that would be comfortable in the parent's lap, have them do that. If you having to undress the child for your physical exam, always have the parent do that. Now, if you're going through your exam and you just cannot console this child, they are freaked out, they're screaming and they're crying, it's okay to give them a little break. And of course, the more times you can make your exams fun, making a game out of it, the better you'll have. So, for example, one technique that I like to do if I'm assessing a child, if I really want to get a good lung assessment, which of course, who wouldn't want to get a really good lung assessment out of your children? What I'll do is I'll hold out my index finger and point making the sign like a number 1 sign, and I'll say, let's pretend this is a candle, and I want you to a birthday candle, and I want you to blow out your birthday candle. Of course, it's appropriate for those that the children that understand are at the age to understand what they're supposed to do with a birthday candle. So that way you can get them to nice big breaths and have them blow it out, and they have fun with that. The rate of growth usually will start to slow to 50% of that in infancy when you're dealing with your early childhood. So that's 1 to 4 years old. So tips for examination. You want to have the child seated first to help examine their eyes and palpate their neck. And you can do your percussion and auscultations here. And then moving the child to a supine position. Here you can assess the abdomen, do the musculoskeletal nervous system. Always assess genitalia last. At the end of the exam, you can have anything that was missed, you can have the patient upright. Here you can have them look at the throat and the ears. Now, the rationale behind this is if by this age they're able to run around. So if you have them in a standing position first, more likely they're going to be running around. If you have them lying down first, sometimes until they may not trust you right away or even at all, but having them go to their back first sometimes will cause a little bit of a distress. As we already mentioned, you'll start measuring blood pressure on age 2, but you still want to get a thorough assessment of all their vital signs. Palpating their neck for any lymph nodes. And at this point, for early childhood kids, some adenopathy might be common. When you're assessing the eyes, you want to cover and uncover the test for positioning and alignment of the eyes. Ears, visualization of the tympanic membrane usually will be your bigger challenge. I think it's still a challenge for younger kids too. And shoot, sometimes it can be a challenge for some older adults too, just depending on their sensitivity. But of course, assessing their nose and sinuses and the maxillary sinuses become present by around age 4. Same technique, if you're thinking back to your BLS training, we know that the brachial pulses are still easier to feel than, say, the radial pulse. Now, at the early childhood age, between 1 to 4, sometimes they'll still have that protuberant abdomen, and that's still considered normal. The liver span and spleen edge, 1 to 2 centimeters below the costal margin is normal. And you can also use the scratch test to palpate for the liver size. For our early childhood, in male genitalia, the testes undescended in the scrotal sac by age 1 is considered abnormal, and you want to refer them. The musculoskeletal exam, they'll have knock knees, for example, from about 18 months to 4 years. And then you want to inspect their spine for scoliosis in any child that is able to stand. Early detection of any scoliosis is super important. A question: you enter the room for a 2-year-old female who is visibly upset and afraid of being at the clinic. To help facilitate the exam, which of the following actions would be most appropriate? Should you just leave the room and return when the child's calm? Should you have the parent leave the room since his or her presence is making the child act out? Should you ask the child's permission to examine a body part? Or should you start and examine the child in the parent's lap? And if you answered examine the child in the parent's lap, you would be correct. Of course, you don't want to ask the child for permission as a review. And you definitely don't want to leave the room, because the child probably won't become calm, or if they do and then you walk back in the room, still probably won't be happy to see you. I definitely don't want the parent to leave the room, because of course that's their comfort zone. In assessing our middle childhood, that's 5 to 10 years. So at this point, the physical exam is a little more straightforward, almost as if you were doing it within a small adult. The nose and paranasal sinuses, the sphenoid sinuses start to become present at age 8, whereas the frontal sinuses between 6 and 7. Peak growth of tonsils is between 8 and 16 years old, so you want to make sure that you do have, you're able to grade tonsils appropriately. So breast development is the first sign of puberty in our young female patients, and this might start as early as age 6. So you definitely want to be familiar with the Tanner stages of breast development, which we will go over here momentarily. And with the musculoskeletal exam, you're still inspecting the spine for scoliosis. So the Tanner stages of breast development, in stage 1 you have, which is the pre-adolescence, you'll only see an elevation of the nipple only. In stage 2 is where breast bud development occurs. There's an elevation of the breast and nipple in a small mound, and then enlargement of the areola diameter. Stage 3, you have further enlargement of and elevation of the breast and areola, but there's no separation between their contours. In stage 4, there's the projection of the areola and the nipple to form a secondary mound, which is above the level of the breast. And then stage 5, this is considered the mature stage. There's a projection of the nipple only. The areola has receded to general contour of the breast, although depending on every patient's a little bit different. Some normal individuals, the areola continues to have a secondary mound. So you want to be familiar with the description of the Tanner stages of breast development for your exam. For male puberty, you're looking also at pubic hair in stage 1. This is the pre-adolescence. So you're looking at pubic hair, penis size, and testes and scrotum. So stage 1, pre-adolescence, there's no pubic hair. The penis is about the same size and proportion as in childhood, and same with the testes and scrotum. Moving on to stage 2, they'll have sparse hair growth, slight or no enlargement of the penis. The testes will be larger and the scrotum larger, but sometimes somewhat reddened and altered in texture. Moving to stage 3, the pubic hair is a little bit darker, coarser, and a little curlier, whereas the penis is a little bit larger in length. And then the testes and scrotum, those are further enlarged. Stage 4, there's coarse and curly hair, as more in the adult, with further enlargement in length and breadth of the penis with development of the glands. And the same with further enlarged in the scrotal skin darkening of the testes and scrotum. Stage 5, here's basically adult hair in quantity and quality. The penis should be adult in size and shape, as well as the testes and scrotum. And then you can review the pubic hair development in our females, stage 1 through stage 5.